Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share some precious tips with you which you may find useful in your line of duty. So welcome to part 67 of our pharmacotherapy MCQ series, which measures in GYNE. Our first question reads, historically, methyl-dopa was the first-line treatment for hypertension and preeclampsia amongst pregnant patients. My question to you is, which of the statements listed below best explains the reason for its decreased popularity for these indications? Is it the fact that it causes hemolytic anemia, or is it the fact that it causes ITP, or is it due to the fact that it causes hepatic failure, or is it because it causes anaphylaxis? I'll give you 10 seconds to choose the correct answer. So it causes hemolytic anemia and it also causes hepatic failure. I would like to remind you that methyl-dopa is associated with drug-induced hepatitis and hemolytic anemia. Now, anaphylaxis and immune thrombocytopenic purpura, which is abbreviated as ITP, aren't caused by methyl-dopa at all. It's not quoted anywhere in the literature. Now, while a patient can be allergic to methyl-dopa, that can technically result in anaphylaxis, this isn't a common occurrence, which led to the decline in the use of methyl-dopa. So that makes D and B wrong and A and C the correct answers. I would like just to add that the role of methyl-dopa in hypertension in pregnancy is declining due to evidence supporting safer alternative therapies which are now available. And I would like to emphasize that labetalol, nifedipine, and hydralazine are the preferred agents for these indications, especially in the context of preeclampsia. Now, while labetalol and hydralazine are the perfect IV agents, if patients are able to tolerate oral medication, nifedipine is an appropriate option. Now, emergent blood pressure goals are thought to target systolic blood pressure less than 160 in this population, and diastolic blood pressure less than 110 millimeters of mercury. Now, definitive therapy for eclampsia is delivery, just as a by the way. However, eclampsia can occur postpartum, typically within 48 hours of delivery. So be very careful when managing these patients postpartum. Let's move to the next question, please. And it reads, Mrs. TNN, a 24-year-old pregnant patient who is in her 28th week of gestation, who is G1 para 0, presents to your accident and emergency department complaining of a throbbing headache. She is awake and able to answer the clinician's question, and she does so appropriately, and she informs the clinician her severe headache started yesterday. And some of the vitals include a heart rate of 53, a blood pressure of 189 systolic, 102 diastolic, a respiratory rate of 17, Oxygen sats of 99 on room air, and the body temperature is 98.8 degrees Fahrenheit. After thorough examination, a clinician diagnoses TNN with preeclampsia. Now, TNN requires blood pressure management, so my question to you is, which of the medications listed below would be the most appropriate for the management of hypertension in TNN now? Would it be manganese, nicardipine, labetalol, or ibuprofen? I'll give you 10 seconds to choose the correct answer. So I would settle for nicardipine. Now, although labetalol is often cited as the drug of choice for preeclampsia related hypertension, given Mrs. TNN's heart rate, which is 53 beats per minute, bordering bradycardia, labetalol may cause clinically relevant and significant bradycardia. It may worsen her situation. Nicardipine is the best choice since it will reliably lower her blood pressure without causing any bradycardia. Now, manganese, which is alternative A, is a detractor. Manganese has no role in the management of hypertension. That was meant to trap you because it sounds like magnesium sulfate. I would like to add that nicardipine is more suitable because it will reliably lower the blood pressure and preserve or even increase the patient's heart rate. It hasn't demonstrated any teratogenicity in pregnancy. If you look at literature, it's categorized as category C. And I would like to add that nicardipine is normally administered via continuous infusion at a rate of 5 to 15 milligrams per hour, but it can be given as a bolus at a dose of 0.5 to 1 milligram in rare circumstances where you need to act very fast. Now, NSAIDs like alternative D, ibuprofen, should be avoided in pregnancy due to the risk of premature closure of the ductus arteriosus in the fetus. It could lead to cardiac complications even before birth. Just as a by the way. Let's move to the next question, please. The next question reads, Mrs. JOO, a 25-year-old expectant patient who is in a 29th week of gestation, who is G2 para 1, presents to your antenatal clinic and is diagnosed with eclampsia. Because JOO is actively seizing, the gynecologist on call at the clinic administers 6 grams of magnesium sulfate and observes her. My question to you is, which of the regimens listed below would be the most appropriate option for Mrs. JOO now? Would you opt to administer thiopental at a dose of 5 milligrams per kilo IV? Or would you settle for Lorazepam 4 milligrams IV? Or would you choose to administer fosphenytoin at a dose of 20 milligrams per kilo IV? Or would you opt for 20 milligrams per kilo IV of phenytoin? I'll give you 10 seconds to choose the correct answer. The best option would be to administer 4 milligrams of Lorazepam IV. Now, after magnesium sulfate, alternative agents for seizures related to eclampsia are the benzodiazepines and propofol, in addition to an emergent CS. If need be, the lady should be taken to theater and a CS should be performed emergently. I would like to add that phenytoin or dilantin or epinephrine is generally not first, neither is it second line treatment for eclampsia. So that makes C and D wrong. Now phosphenytoin, which is marketed as Cerebix, is a prodrug of phenytoin, so it makes it a wrong choice. And I would like to add that high dose magnesium sulfate, 4 to 6 grams, is the drug of choice for eclampsia. Now magnesium sulfate for this indication must be administered via IV bolus rather than the slow infusion, because this is an emergency. It needs quick action. I would like to add that calcium gluconate should be readily available in any treatment area that administers high dose magnesium sulfate, since magnesium can act as a calcium antagonist. And I would like to add that propofol is relatively safe in pregnancy. It's considered category B. However, administration of propofol in such a case, insufficient doses to deal with a case like this one, necessitates endotracheal intubation and even mechanical ventilation. So it would not be an ideal choice in this particular clinical scenario. And if IV access is not available and magnesium sulfate must be administered, then it should be administered via IM, where 2 simultaneous 4-gram injections are administered into each buttock. That's just a by the way, in case you cannot attain IV access. Let's move to the next question. And the next question reads, Mrs. JMK, a 26-year-old expectant patient with gestational hypertension, presents to your accident and emergency department. Preeclampsia has complicated her current pregnancy, though a few hours after presentation, she has ultimately delivered a healthy, full-term baby boy. So my question to you is, which of the therapies listed below would be the best option for JMK? Now, would it be Lorazepam, Losartan, Nabetolol, or lisinopril? I'll give you 10 seconds to choose the correct answer. Labetalol would be the best choice. Now, labetalol is one of the first-line options for the management of hypertension in pregnancy. I would like to add that B and D, ACE inhibitors and angiotensin receptor blockers, are contraindicated in pregnancy, so that makes them wrong. Then Lorazepam isn't an appropriate agent in hypertension and is also considered contraindicated during pregnancy unless you are treating seizures that are unresponsive to magnesium sulfate. So remember that. I would like to add that labetalol, nifedipine, and hydralazine are the first-line agents for the management of preeclampsia and any related hypertension. Now, while labetalol and hydralazine are preferred IV agents, they can also be used orally if need arises. I would like to add that nifedipine is only available in the oral dosage form. We do not have an injectable version of nifedipine. I would like to remind you that labetalol is a non-selective beta agonist, it's a non-selective beta antagonist and an alpha-1 antagonist. Therefore, caution is essential in patients with reactive airway disease. It could cause bronchoconstriction, and in asthmatics that would be very dangerous. Now, like methyl dopa, hydralazine is associated with hematologic adverse events, though they are less prevalent in hydralazine use. I would also like to add that hydralazine may also induce autoimmune responses and lupus-like syndromes, so use it cautiously in this group of patients. And at appropriate doses, hydralazine induces arteriodilatation rather than venodilatation. It lowers BP by dilating the arteries. That's just a by the way. Let's move to the next slide. And the question reads, Mrs. O.T.O., a 33-year-old expectant patient, was intubated with succinylcholine and etomidate for the management of preeclampsia. And prior to this procedure, she had received magnesium sulfate via the IV route at appropriate doses for eclampsia treatment, the 4 to 6 gram range. So my question to you is, how will magnesium sulfate affect the action of succinylcholine? Will it lead to a faster onset of action? Would it diminish the degree of paralysis? Would it lead to a shortened duration of action? Or would it result in prolonged duration of action? I'll give you 10 seconds to choose the correct answer. Lead both to a faster onset of action, and it would also prolong the duration of action. Now, at doses used in the treatment of eclampsia, magnesium sulfate has some neuromuscular blocking activity. This effect is additive to concomitant neuromuscular blocking drugs such as succinylcholine. And just as a by the way, I would like to digress and say that aminoglycosides also possess weak neuromuscular blocking activity that can also be additive with neuromuscular blocking drugs if they are co-administered. And I would like to add that succinylcholine can be used in pregnancy, and given its short duration of action, it is ideal in the setting of pregnancy. Now, if excessive paralysis occurs during the use of a drug like, for example, rocuronium or vecuronium, a reversal agent like Sugamadex, which is marketed as Bridion, can be used. But this product cannot be used in the case of succinylcholine overdose, since it is a depolarizing neuromuscular blocker. Just as a by the way. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers out there. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come, and I thank you all for viewing and for listening to this video. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you in the next video, which will be part 68 of our pharmacotherapy MCQ series. Thank you very much.